March is Lymphedema Awareness Month. This resource has been created to provide education on the condition as well as provide information on treatment options. Mount Wilgar is an internationally recognised centre of excellence in the conservative management of lymphedema. The lymphatic system works alongside our vascular system, and its two primary purposes are to maintain the protein concentration in the extracellular fluid and detect and destroy pathogens and remove waste products from the body. The lymphatic system is made up of a network of lymphatic vessels that transport fluid to clusters of lymph nodes. Lymphedema is the accumulation of protein-rich fluid in the tissues that results in swelling in one or more regions of the body. It most commonly occurs in the arms and legs, though can be present in the trunk, genitals, and other regions of the body. Lymphedema is grouped into two main classifications, primary and secondary. People can be born with primary lymphedemas, which means there is a malformation of the lymphatic system from birth. Swelling can occur for many reasons: trauma, wounds, because someone is wheelchair bound with their legs in a dependent position for prolonged periods. They may have a cardiac issue causing swelling to accumulate and overwhelm the lymphatic system. If someone develops chronic swelling and there is compromised lymphatic drainage, it is termed a secondary lymphedema. People are often familiar with lymphedema associated with cancer treatment. This occurs when there is damage to the lymphatic system following treatment for cancer. Most commonly, if cancer spreads to the lymph nodes, those nodes need to be removed as part of that patient's treatment. This is a problem because lymph fluid flows along vessels and is filtered and processed by lymph nodes. If lymph nodes are removed, that means that those lymphatic vessels no longer have a viable pathway along which to move fluid. 2, if patients have radiotherapy or chemotherapy as part of their treatment, this can damage lymphatic vessels, which then disrupts pathways and leads to a backlog of fluid in that body region. 2, regions of lymph nodes can be obstructed by tumours. One of the most common causes of lymphedema in Australia are secondary lymphedemas in the arm following breast cancer treatment. Lymph nodes in the axilla are removed or radiated, and there is disruption to the flow of lymphatic pathways in the arm, resulting in swelling. Not all patients develop lymphedema following cancer treatment, though there are certain factors that increase the likelihood. These include the extent of their cancer surgery and the number of lymph nodes removed, radiation therapy, so some of the smaller lymphatic vessels lie only a few millimeters below the skin surface. So when patients have radiation therapy and sustain burns and skin trauma to those areas, the underlying lymphatics are also implicated. A history of wounds and trauma, so having infected drain sites or infected surgical sites, can increase the risk. Also, if they have a history of cellulitis, and having a high BMI. So there is definitive evidence that this increases the risk of lymphedema in breast cancer patients. So what should we be looking for in our patients? What are the early signs and when should we be worried? The first thing to remember is that in the cancer population, lymph node removal and radiotherapy treatment are risk factors for developing lymphedema. So any information that you can impart to patients undergoing these treatments is going to be valuable. The patient may report swelling that comes and goes. It's quite typical for swelling to be worse at the end of the day because the arm or leg has been down and gravity causes a pooling of swelling in the limbs. But then it settles overnight when the patient is lying. It can be difficult when there is a fluctuant presentation in these early stages because the patient may think nothing of it. Recurrent episodes of cellulitis are common in people with compromised lymphatics. Feelings of heaviness and aching, tightness of clothing, rings and watches. Patients report not being able to get their rings off as easily as they normally would, or that their watch really seems to be cutting in. For leg lymphedema, people report shoes feeling very tight or that they have deep indentations left by their socks. There are, of course, other causes of swelling, especially in patients who are early in their cancer treatment or diagnosis. In particular, we'd want to screen for blood clots or if there are cardiac and renal issues. Lymphedema cannot be cured, and it is often progressive. So identifying and managing it early means that patients are more likely to prevent chronic and progressive changes that can lead to a lifetime of disability. Wounds are often complicated by the presence of lymphedema. Chronic edema or lymphedema is associated with perpetual inflammation and tissue hypoxia. The skin's ability to act as a physical and immunological barrier is compromised, which predisposes the individual to infection, skin irritation, and poor wound healing. Volume reduction and lymphedema management are often crucial to wound healing in these patients. These photos demonstrate the difference that a week's worth of therapy can make to a patient's wounds. So now that you know what it looks like and what causes it, what's next for your patient? The best answer is to refer them to a lymphedema therapist. Lymph therapists are health professionals who have obtained an additional clinical qualification in the management of swelling. For cancer patients at risk of lymphedema, the gold standard in management is to have all patients referred to a therapist preoperatively so that they can have baseline measures taken. The old school form of measuring is to use a tape measure to determine the circumference of the limb at different points. We still routinely do this. A newer and more sophisticated way of doing it is to take a bioimpedance measure. Patients stand on a machine that sends a very low frequency current through the limb. The machine compares how quickly that current travels through the affected versus the unaffected limb. Then it does a bunch of complex calculations and generates a numerical value. Essentially, the more fluid the limb has, the more quickly the current travels. We have that number as a baseline and can then measure again soon post-operatively and then at regular intervals after that. If patients are unable to attend a preoperative review, it is ideal for them to be seen by a therapist soon after surgery, and we use the same techniques to take a baseline and then monitor over subsequent reviews. If patients do develop lymphedema, we educate on management. We provide information on skincare, so keeping the skin well moisturized and preventing and managing wounds, and provide education on exercise. But most importantly, we compress. Compression can be applied in the form of a compression garment or compression bandaging. Compression for lymphedema is applied in a graduated manner. So the compression at the foot is higher than the compression at the knee, so there is one-way movement of fluid. Pictured here are examples of compression garments for the arm and the leg. For patients early on in their lymphedema journey, a well-fitting compression garment can do a lot to prevent skin changes and limb size and shape changes. There are lots of other treatment modalities for the management of lymphedema, including the use of compression pumps, laser, manual lymphatic drainage, and the use of negative pressure devices.